Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we continue with our weekly section Flash Code, a place to explore the world of acute coronary syndromes and primary angioplasties. Let's begin. This week we have a man of 61 years of age, smoker and with family backgrounds of arterial hypertension and chronic obstructive pulmonary disease. He arrives at our unit with the diagnosis of STEMI of approximately 5 hours of evolution. His clinical situation is stable, but chest pain persists. This is the electrocardiogram of our patient. As you can see, it is evident the existence of changes on the ventricular repolarization. These alterations express as elevations or descents of the ST segment in some leads, and they suggest an acute myocardial lesion. Could you identify these disturbances? That's it. In this electrocardiogram, we have the next alterations. First, elevation of the ST segment from V1 to V4. It is curious that regarding the rest of anterior leads, V3 presents an ST segment practically normal, probably due to an anomalous localization of the electrode. Second, Q waves on inferior leads. These are 2, 3, and ABF, which suggests an old infarct on this location. And third, QRS complexes with voltages inferior to 5 mm in frontal leads and inferior to 10 mm in almost all precordial leads, which is known as microvoltage. This tells us that we have an acute myocardial lesion of subepicardial or transmural characteristics on the left ventricle. This translates clinically to a STEMI. However, we must not forget the microvoltage. It could be a sign of pericardial effusion, which might be related to cardiac rupture in acute myocardial infarctions. A fast transthoracic echocardiography allowed us to, in this case, discard this complication and assign the microvoltage to another cause, the COPD. But what clinical relevance does this have? Very simple. ST segment elevation myocardial infarction is the regular clinical manifestation of a complete blockage of a coronary artery and constitutes a cardiological emergency where every second counts. In this way, our main objective is to open the artery as soon as possible, whether it is using fibrinolysis or primary angioplasty. In this case, primary angioplasty was performed. As you can see, right coronary artery is open and has no significant lesions. This could be contradictory because electrocardiogram disturbances suggested an old necrosis in the territory of this blood vessel. We are talking about the Q waves that we previously found on inferior leads. However, sometimes electrocardiogram changes on inferior leads can be found when the anterior descending artery is ill and has a development that makes it turn around the apex. So let's take a look at the left coronary tree. As you can see in this projection, the anterior descending artery is blocked at its middle segment, a predictable finding according to the ST alterations found on anterior leads. However, it is interesting to point out that the occlusion is located distally regarding the origin of the diagonal branches. Because of this motive, the flow of these branches is not altered, and the ST segment does not have any alterations on the leads 1 and AVL. Now we know where the obstruction is and we only need to treat it. First thing to do is to pass an angioplasty guide wire through the closure. Sometimes, as in this case, passing the guide wire partially opens the artery and allows us to see part of the distal bed. In this case, the next step was to implant a stent on the blockage zone. This props the artery and returns blood flow. And this is the final result. As you can see, we have recovered the blood flow of the artery after implanting the stent, obtaining a good angiographic outcome and without pre-procedure complications. In this way, with the artery open, the ST alterations are progressively improving and pain disappears. being this emergency resolved, and with it, our chapter. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!